Hi, everyone. Welcome to my channel, Lively Life Snippets. I tried to relive the past memories as they made me who I am today. Thank you for being there for me. Let's throw back to the first time I made a PowerPoint presentation as a PRP. It was a CME session to all the pharmacy staff in the store in outpatient pharmacy in August 2018. I was just less than a month old as a PRP. Shall I consider myself as neonate PRP? So, the topic of my presentation is ready to beat malaria. Please note that any content of this video does not substitute professional medical advices. If you have any health issues, please speak to your doctor and healthcare team. This video is a sample of few presentations that I had done during my Provisionally Registered Pharmacist PRP training in Malaysia.
First of all, why malaria is an alert, and why should we care? This is because malaria kills a child every 2 minutes, especially in countries highlighted in blue such as Nigeria, Democratic Republic of the Congo and others. Nearly 80% of malaria deaths globally are found in 15 countries. Another challenge is that the parasites evolved to become drug-resistant, further shrinking the current treatment options. According to National Strategic Plan for the Elimination of Malaria, NSPEM, for the year 2011 to 2020, we aim to eliminate locally acquired human-only malaria by 2020, which is just another 1-year time. There are 4 species of Plasmodium which are pathogenic, namely Plasmodium falciparum, Plasmodium malariae, Plasmodium vivax and Plasmodium ovale. Please note that only one of the life stages of each Plasmodium species is being shown here in thin blood films.
In this slide, we are going to talk about the Plasmodium life cycles. Firstly, a mosquito sucks the blood of a patient. At the same time, saliva containing the parasites, sporozoae, enter the bloodstream. Sporozoates are carried in the body until they reach the liver to attack the hepatocytes. They multiples and kills the hepatocytes, releasing merozoates into bloodstream. The time period before merozoates enter the blood from the liver is termed as the pre-patent period. Incubation period is about 12 days for Plasmodium falciparum and Plasmodium knowlesi, 14 days for Plasmodium vivax and Plasmodium ovale and 30 days for Plasmodium malariae. Upon infecting erythrocytes, the parasites undergo ring stage to form trophozoates and then schizonts. The clinical symptoms begin after the rupture of the mature schizont-infected erythrocytes, releasing the merozoates and toxic products of the parasite's metabolism into the blood. This erythrocytic cycle continues for many rounds. It takes 48 hours for Plasmodium falciparum, Plasmodium vivax and Plasmodium ovale, 24 hours for Plasmodium knowlesi and 72 hours for Plasmodium malariae. While most undergo erythrocytic stage, some parasites go into sexual differentiation to produce male and female gametocytes. When another mosquito sucks patient blood, it sucks up gametocytes into its body too. The gametocytes of opposite sex fuse to form zygote, which then develops into sporozoates and stored in salivary glands of the mosquito for the next meal as well as next target of infection. The cycles repeat again from the start. There are 4 types of drugs acting on erythrocytic stage, namely artemisinin, quinolones, atovaquone on their targets respectively. Doxycycline interrupts with the release of merozoates to infect red blood cells. Primaquine acts on both the liver stage and the formation of gametocytes.
What will be the aim of treatment? First, will be to alleviate symptoms such as fever. Second, to prevent relapses. Third, to limit the spread of disease especially from liver to whole body. Artemisinin-based combination therapy is the suggested first-line treatment for all species of Plasmodium species. This group include Ryamate and Astaxonate mefloquine, ASMQ. These medicines are derived from plant as shown in the picture.
To treat uncomplicated new falciparum infection, the first-line option is Ryamate tablet, which contain 20 mg artemether and 120 mg lumefantrine in 1 tablet. 1 course of treatment lasts for 3 days, containing 6 doses. The first and second dose needs to be 8 hours apart. For third dose onwards, 12 hours apart between doses. The number of tablets per doses is depended on the weight and age. For adult and children more than or equal to 12 years old with at least 35 kilograms, 4 tabs per dose is recommended and reduced to 3 tabs for children between 25 kg to 35 kg body weight. For children weigh 15 kg to 25 kg require 2 tabs per dose, while children with 5 kg to 15 kg require 1 tab per dose. On a side note, Ryamet is a List B item and can be prescribed by medical officers. One useful counseling point to share with patients are to take Ryamet tablets with a fatty meal such as milk or fried food or fast food meal.
Another alternative is artesunate mefloquine tablets. This drug is being formulated as once-a-day dosing for 3-day course. 2 strengths are available, 100 plus 220 mg and 25 plus 55 mg. It was packaged as 3 tablets or 6 tablets for both pediatric and adult use. The age group and weight are clearly stated at the bottom left-hand corner of the medicines boxes as shown in the slide. Some precautions while prescribing artesunate and mefloquine are: do not use in pregnancy and in children with epilepsy because it may trigger seizure, do not use together with quinine, chloroquine, halofantrine because it may arrhythmia, do not repeat course within 60 days because reuse of mefloquine may increase risk of neuropsychiatric reactions. Is artemisinin same to be consumed by pregnant mothers? For the first trimester, there are limited data on safety, hence, the drugs of choice will be a combination of quinine and clindamycin for a week. For second and trimesters, there are no adverse effects on mother or fetus and therefore, artemisinin can be safely used.
Second alternatives will be a combination of oral quinine, which is dosed as 10 mg per kilogram 3 times a day, and oral doxycycline at a dose of 100 mg twice daily for 1 week. Doxycycline is contraindicated for pregnant and lactating women, children less than 8 years old because it may cause tooth discoloration. Another anti-malarial drug is primaquine. It is dosed at 0.75 mg per kilogram until a maximum of 45 mg. It should be started on day 1 of artemisinin regime and quinine. It should be taken with food to avoid gastrointestinal discomfort. Primaquine should not be used in pregnant mothers, breastfeeding women and infant less than 12 months old. Use cautiously in patients with unknown G6PD status. Start with a low dose of 0.25 mg per kilogram. It is best to check G6PD status before giving primaquine to children less than 12 years old to reduce the risk of hemolysis.
If treatment fails or there is a relapse of falciparum infections, first-line management will be using another alternatives of first-line treatment. In other words, if Ryamet is used as first-line but failed, use artesunate and mefloquine and vice versa. Otherwise, a combination of oral quinine and doxycycline can be used. Either way, primaquine has to be added as single dose once a day but need to check patient's G6PD status before administering to reduce risk of hemolysis. If doxycycline is contraindicated such as in children, it can be substituted with clindamycin and oral artesunate at a dose of 10 mg per kilogram twice daily and 4 mg per kilogram once a day for a week respectively.
Some of the serious complications of severe malaria include but not limited to coma, cerebral malaria, acute pulmonary edema, metabolic acidosis, acute renal failure, severe anemia, hypoglycemia and others. For severe falciparum infection, it should be managed in intensive care unit (ICU). Recommended first-line treatment is intravenous artesunate 2.4 mg per kilogram at 0-hour, 12-hour, 24-hour and daily subsequently till day 7. Same dose should be used for all stages of pregnancy. If intravenous is not available, give intramuscularly and it shall be administered before transfer to tertiary center. A minimum of 3 doses of parental artesunate should be given within 24 hours or till patient can take medicines orally. Complete the remaining course of treatment with oral Ryamet or artesunate and mefloquine. If patients cannot tolerate intravenous artesunate, another alternative is to use intravenous quinine with 2 different infusion rates as shown in green and blue box. Intravenous quinine should be prescribed together with oral doxycycline 100 mg twice daily for a week. For patients with renal and hepatic impairment, quinine dose reduced by 1/3 after 48 hours, except for those receiving hemodialysis. All patients on intravenous quinine should have their blood glucose and ECG monitored. If doxycycline is contraindicated, such as in children and pregnant mothers, it should be substituted with clindamycin 450 mg 3 times a day for a week.
For Plasmodium vivax or oval new infection, stat oral chloroquine at a dose of 10 mg base per kilogram with a maximum dose of 600 mg. This is followed by 5 mg base per kilogram with a maximum dose of 300 mg 6 hours later of the first dose and the at day 2 and day 3. Chloroquine should be given with primaquine at a dose of 0.5 mg per kilogram with a maximum dose of 30 mg once a day for 2 weeks. If the above first-line treatment fails or the parasites are resistant, Ryamet 3-day course and primaquine maximum dose of 30 mg once a day for 2 weeks shall be given. If the patient is pregnant, she should be given full course of chloroquine followed by 300 mg weekly until delivery. Primaquine should be delayed until after delivery. For Plasmodium malariae or Knowlesy new infection, recommended first-line treatment is Ryamet for 3 days. If patient does not tolerate, 2 alternatives which can be considered are artesunate mefloquine or oral chloroquine. If the infection is severe, patient should be treated as severe Plasmodium falciparum with the same first-line intravenous artesunate and oral doxycycline. In Sabah and Sarawak, presume Plasmodium malariae to be Plasmodium knowlesy. Therefore, primaquine is not needed as no hypnozoites are formed. There are slight differences among the Malaysia, UK and US guidelines. Some drugs might be available in one country but may not be available in other countries. Parasites resistance pattern affects drug choices too.
In terms of chemoprophylaxis, 2 main types are available. Firstly, suppressive antimalarial agents kill parasite once it has entered red blood cell. As a result, they must be continued 4 weeks after leaving area of risk. Some examples are chloroquine, proguanil, mefloquine, list A** item, and doxycycline. Another group of antimalarial agents act upon the cause of infection as they target both liver and blood stages. They only need to be continued for 7 days after leaving area of risk. Some examples include zatovaquone proguanil, malarone, and primaquine. Chemoprophylaxis agents which can be prescribed by medical officer is doxycycline, which is a list B item. Malarone is not in Blue Book, hence, supply is through private healthcare system, while mefloquine is an list A** item which can only be initiated by certain specialist in hospital.
The most important counseling point to convey to patient is prevention is better than cure. To prevent mosquitoes bites, patients can use insect repellent, wear long sleeves and trousers and sleep in a mosquito-free setting, or use an insecticide-treated bed nets. Other than that, it is good to reassure patients they are not infectious to others. You may discuss about the risk of having caught malaria or relapse, and see doctor if symptoms such as fever develop as early as possible. Patients should be warned about the symptoms of hemolysis for patients with unknown G6PD status taking artesunate and primaquine. Patients should be advised about malaria prevention in all future travels.
I will compile and produce another video for this session. Stay tuned. The end of my first PRP presentation. Thank you for watching Lively Life Snippets, and if you like my videos, hit the like and share button. Don't forget to subscribe, and see you all in the next episode.